Good morning. We are discussing the innervation of teeth, recent and some old forgotten aspects, part 4. And in part 4, this is the first presentation. The second one will be presented later. Here we go with the PowerPoint presentation. As I share the screen, we are discussing here Bifid and Trifid Mandibular Canal and the inferior alveolar now. The all important inferior alveolar now. About the terminology, let me mention that now the term mandibular foramen and mandibular canal are replaced by inferior alveolar foramen and inferior alveolar canal, because they transmit the structures of the same name. But everywhere we can accept the change or not is a matter that we have to ponder from time to time. Now let us have a look at the inferior alveolar now as it passes through the, I will use the term mandibular canal because everybody is more familiar with that term. And already I have projected this slide previously, but still I would like to show you the branches of the inferior alveolar now here. This is the now. Actually, it is neurovascular bundle. This is the mantle. And the arrow is the incisive branch, which we have discussed previously here. In the other diagram, with the implant in place, we can see some radiolucencies, and they are here. And they should not be confused with the radiolucencies of the cancerous bone, which you find throughout here, because the compact is at the periphery, particularly. And rest of the mandible in cross section is filled up with the cancerous bone. And now the question which is asked is there any compact bone immediately around the inferior alveolar neurovascular bundle? The answer is yes, but it is not complete. It is perforated, and in the dissection, cadaveric dissection, we remove that compact bone to expose the neurovascular bundle. And that compact bone is different from the compact bone that we find on the surface, which we have already examined along with the implant, right on the surface of the mandible. So this inner compact bone can be expressed as corticalization. Corticalization. And this particular slide is useful when you talk about lateralization of the inferior alveolar neurovascular bundle, or transposition or repositioning. I'm not discussing the details there. At that time, the inferior alveolar neuromuscular bundle is displaced laterally or moved from its original position, so that the implant does not impinge upon the neurovascular bundle. And the bundle is kept either medial or lateral to the implant as per the requirement. Now, this is just one canal which everybody is familiar with, the inferior alveolar canal, incisive canal, or the mandibular canal. But if there are additional canals, many are not familiar. It is with the advent of implantology, oral dental, that such additional canals have been discovered. It is the contribution of oral dental implantology to the knowledge of anatomy. When I was a teacher for many years in the dental colleges, I never discussed this particular additional canal, and only after 2015 I have started discussing this additional canal. And they are very rare. So, let us see. It's difficult to get the images of this canal from our clinicians. And before we go to that Bifid or Trifid canal, we have to think of the development here. The neurovascular bundle is earlier in development. It is there before the mandible develops. And then the bone of the mandible develops around that. And to start with, that bone is the cancellous bone. I will show you here. This is all cancellous bone. So, if there are two inferior alveolar neurovascular bundle anywhere, then around each one the cancellous bone will develop. And it is from that cancellous bone around the inferior alveolar neurovascular bundle, we get the corticalization that we referred to in the previous slide. I already shown this slide previously. But very important thing is, imagine implants in place of teeth. And whatever is seen is the neurovascular bundle. It is not the nerve only. Vessels are also there. And in this particular dissection, the neurovascular bundle is very close to the molars, the mandibular molars which are shown here. And about the middle of the body of the mandible. And we can see that the neurovascular bundle is lateral to the apices of the roots of the molars. But what you find in this case may not be found in other cases. That's why I often say that every case is unique. Every individual is unique. And that's why you have to go for the CBCT in every case. In implantology, the periapical intraoral radiographs, then the orthophantomograms are not ideal. You require CT scan or CBCT. And beyond that, the MRI will be better, but very costly. And that's why we have to depend upon CBCT. And now we go to the next slide. Along with the vessel, artery and vein, the nerve is depicted here. But don't forget the lymph vessels. I have written there. Lymph vessels should also be included. They are there. Obviously, this is a section of the mandibular canal. And the mandibular canal is not the root canal. And this is for the endodontist to know and consider while filling the root of a tooth. One should not fill the mandibular canal, even partly. That's a lesson to be learned from this image. And now the exact Bifid mandibular canal begins. And I will sit and so. Now look at the retromolar foramen and canal. Here, this is the foramen. And this is the canal, retromolar canal. Taking origin at that level. And this is the mandibular canal, as you can easily see. The molar, horizontal infection is it? But behind the molar, retromolar, foramen and canal. Such a canal will be called the Bifid Mandibular Canal. And this is from Iwanaga and Tubbs 2019. And now 2020, Zhao et al. Have found the bifid canal like this. I will trace it. Here is one canal, the main one, and the second one at the arrow. Not very clear in this. Let us see the next one. And here, this is the main canal, and this is a branch of it. With this one, and you can see the dental canal there, and this is the main canal. And likewise, in the next one, you can see. Well, corticalization is this. This is the white line is corticalization. And similarly here. Similarly there. There. And this is the main canal. And the other one, you can say accessory canal. Of all the 321 patients, 26.17% cases of bifid mandibular canal and 16.36% sides of unilateral bifurcation were observed. (84 out of 321), 26.17% cases showed bifid mandibular canal. And unilateral bifurcation was observed in 16.36% cases. Now, let us go to the next. And here, the implant is impinging upon, you can see, the mandibular canal, the accessory one. Here is the implant. The main mandibular canal is here. Here. And the accessory is here. And that arrow probably shows the beginning. Okay, this is that accessory canal. Based on the work of Renton and New 2015. So why the bifid and trifid canals are important in oral dental implantology? One can get idea from such images. And one has to go for a shorter implant in such cases or one has to go for another kind of treatment, because the neurovascular bundle, the accessory ortho, should be protected thoroughly, and implants should not violate that, should not touch that. Very important. And the next one, Bifid Mandibular Canal, retromonal canal including courtesy of Von Ox T. Lozen of S. 2017. This is from their clinical oral anatomy book. Now, I will again stand up and we discuss further here. Mean frequency 9.8 to 66.5% of patients. It's a very wide range. And 0.9 to 46.5% of size in CBCT and hemimandible. Mean length is 6.9 to 24.5 millimeter in forward type. We'll discuss about the types after some time. Mean diameter 0.2 to 4.35 millimeter. So sometimes they are very long, sometimes they are very wide. And then from another study by Von Ark T along with Bonkin 2021. This is the latest and quite comprehensive. I would like to recommend this to those who are interested in more details. Mean frequency 1.35 to 66.5% of patients and 15.6 to 46.5% of size in CBCT and hemimandible. So the higher prevalence is the same as the previous reference. Mean length, well, 2.2 to 48.5 millimeter. Oh, that 48.5 millimeter is double of what you find in the previous reference. And diameter 0.27 to 5.55 millimeter. And we go forward. Well, we will discuss the types of the Bifid and Trifid Mandibular Canal in part 2. But here, I read out the comment. Some subtypes of Bifid Mandibular Canal and Trifid Mandibular Canal simply represent normal inferior alveolar nerve branches, like the retromolar branch, molar branch, alveolar branch or dental branch, large mental branch, or a communicating branch. Others such as Nato's type 3 BMC and forward canal might be a true Bifid mandibular canal. Those which are not going to teeth and those who are or which are lost in the bone. They may be true bifid mandibular canal. And the reference is among the latest, 2022, Yuanaga et al. And now classification of the bifid mandibular canal. And in the 6,000 radiograph studies, bifid mandibular canals were seen in 57 radiographs, an incidence of 0.95%. The study by Langley, 1985, and obviously one would like to clarify which kind of radiograph. Were they OPG? We have to confirm. And now the different classes which are shown here, I will show you. Here it is. Now see in this one, one branch is shown there, going behind the last molar. This is unilateral, but it may be bilateral like this. This is retromolar, they have called it type 1. Now what is type 2? Well, on one side it is normal, on the other side a foramen is enclosed within the neurovascular bundle. So a branch is there which reunites with the main mandibular canal. It happens on both the sides, bilateral, type 2. And this is happening, we have to consider whether it is happening in the body or ramen. This is extending into the body from the ramen. And here it is limited to the ramus only. A big foramen is found within the mandibular canal there, which is bifurcated and then reunited. And here, bilateral extending into the body from the ramen. And a combination of type 1 and 2 is called type 3, and that is what you find here. This is retromolar branch, and this is what you find in the ramus mostly, and similar to type 2 that we have seen here. And finally, type 4 is originating from two mandibular foramina, very important, 1 and 2. And then the two canals which unite to form single. Other side, it is normal. So sometimes you find an additional foramen, very important to know. And in the next slide, we find more clearly from the works of Valenzuela et al. 2021, and you can see a long foramen is enclosed here. The main mandibular canal, and then in the molar region you find a branch arising from the main mandibular canal and then reuniting with the main canal. And in a cross section you will find two canals like this. If the section is taken here, and here's the main canal, and then a branch going straight away to a root of the second molar in this example. This is the dental branch. And here, main canal, this forward going canal is lost in the bone. It is going nowhere. And this is a little bit different from C. The smaller canal is on one side here, this is on the other side. And you have to find out the buccal and lingual. And finally, the retromolar canal from the main canal. Others have called it type 1. This is retromolar, this is dental, this is forward. And we go to the next slide. And this is the last slide in this part, I think. And in the radiographs, various types are shown. And you can see type 1, retromolar, type 2 with a foramen inside it and mostly located in the ramus region, type 3 with a combination of 1 and 2, as you can see, this is 1, this is 2, and type 4, well, only unilaterally present, and there are 2 foramina, obviously, in the ramus region, 2 mandibular foramina or inferior alveolar foramina. In this part, I have not included this foramen, which is extra foramen. In the next part, I will be showing you that foramen. And well, this is the part 4, and in that the sub part 1. And obviously, I think we are all looking forward to part 2. That includes references also. So basically, to finish in time, and the presentation does not become very lengthy, I have divided into 2 parts. And I am looking for the Bifid and Trifid Mandibular Canal images from our clinicians. These are very rare, so difficult to get them. But I think in part 2 or sub part 2, I may be able to include such images from our clinicians. Otherwise, it will be in future. Well, thank you very much. Innervation of teeth is a big topic, and a lot of new things, recent things are because of the arrival of oral dental implantology, as I have mentioned previously. Every additional foramen, which you can call accessory mandibular foramen, every additional canal, you can call it accessory mandibular canal, require that one studies the contents. For many such foramina and canals, we know the contents, but for many others we do not know. So obviously the researches are on to discover the contents. It is difficult in a patient to examine the contents because you require MRI, which is very costly. So we have to accept for the time being the incompleteness in the knowledge that we possess. Thank you all.